Hello, I'm Etyene Schnurr, and what I bring to you today is learnings and insights on ceramic implants based on biology and based also on demography. Demography because I want to start this talk with a question. Who is the dentist and who are the patients that would be involved with ceramic implants for the next 20 years? We, as business people, as researchers, clinicians, we should prepare ourselves to meet the expectations of this public. And why I'm talking about that? I'm talking about that because my hypothesis for the future is that the future of implantology depends on immediate implantation with ceramic implants at tissue level using blood concentrates and micronutrients. And to test my hypothesis, we need to step back in the beginning of the ceramic implants, where the knowledge was an empty box. Nobody was talking about that. There was no design. Every development on ceramic implants were based on the user experience. And I can also rename this picture as research and as the patient needs, just like this. And as I want to address my initial question, I can also rename this picture as the baby boomers, and on the other side, the generation X, Y, Zeta. The baby boomers, the generation that grew up under strict rules, workaholics, they made a lot of money, but they won't be the patients 20 years from now. On the other side, the generation X, Y, Zeta, iPhone generation. They grow in a completely different mindset, but they would be the dentists and they would be the patients requiring ceramic implants. And as I feel that is so important that we focus on this new generation, I brought to you some definitions of this generation. The generation X, Y, Zeta is thinking less. They don't want complications. They don't want screws. They don't want abutments. They don't want complicated prostheses. They want something that they click, is very effective and very aesthetic, like the iPhone. They are very worried about their health. They are worried about not having metals, not having low prognosis diagnoses. They are worried about what they eat. They are gluten-free, lactose-free, they are vegan, and they are 100% digital. Their office are full of technology, tomography, scans. They want to work with navigation systems, and they want to solve problems using informatics. I'm sorry, but we are the majority. The women are the majority of this generation, and we learn what is work-life separation. That means we want to plan our cases in advance. We want to have more time and not bring problems back home from these patients, because we want to have a surgery as atraumatic and without blood as possible. And that's why I use the quote of Dr. Volz, the developer of SDS ceramic implants, the world leader market in ceramic implants, that say immediate implantation is the arthroscopy of dentistry, and that fits very nicely the new generation. With this brief introduction, I want to bring you some clinical evidence to drive your outcomes into a successful treatment using ceramic implants and immediate implantation. The first point is understanding osteoimmunology. After tooth extraction, the response that arises from the tissues undergo a second round healing to a scarring form on its ridge. The pressure on the marginal flaps will further lead to a closure of this wound and atrophy. That's why immediate implantation or any kind of augmentation should apply to prevent atrophy, because atrophy worsens over time. Under a histological perspective, after 6 months, you see a bone that is demineralized and avascular, and that is progressively. Technically, until 6 weeks, you can still use the same diameter and length of your implant, but after 6 months, atrophy requires a shorter implant. And that is as late your implantation as shorter implant, and worse the relationship with your future prosthetic restoration, putting in risk your stability and osseointegration. Late implantation also have the balance between osteoclast and osteoblast, favoring resorption. And that makes way more important to use micronutrients such as vitamin D, vitamin K2, vitamin C, omega-3. That doesn't happen with the immediate implantation, where the bone formation is already expected. I did analyze in a long-term analysis the immediate and late implantation of 1-piece and 2-piece SDS implants and the risk of fracture. As you can see in this graph, the numbers of fracture are very low. And if you associate this procedure with bone augmentation and PRF, these numbers are even lower, reaching almost 0. As much as our understanding in oral biology and wound management evolve, so have our understanding on the drilling system. Ceramic implants should drill an implant without apical or cortical bone compression, just as enable enough space between the implant and the bone to cells circulation and blood. That creates what we know as the healing chambers, those bioactive areas that can generate nail bone formation with a bone that sometimes is denser as the natural bone. That gives us the opportunity to implant immediate implants in situations even when you have no primary stability. Like here, where we placed 2 implants on the premolar upper jaw of this patient with no primary stability, and the stability comes from the bone implant stability system, BIS. You see that we follow the open healing concept, and after 4 months, the patient came back to us when we took out the mesh, and that's look like this. This patient then undergo one of the parameter analysis for osseointegration, the any-check, and that would not surprise me if the any-check numbers on the EST scale show up numbers higher for the floating implants. Let's take a look together. That's the neighborhood implant, 80 on the EST scale, and now the floating implants. 82 in the EST scale, or a bone that is denser than the natural bone. And that doesn't happen with 1 patient, but with 52 patients that undergo this retrospective study, already with 1 year follow-up. All the patients after 4 months were evaluated with a any-check after immediate or late implantation, and they reached an average of 65 EST on the any-check scale. That defines a bone that is safe for further restoration and prosthetic restoration. That opens us the possibility also to implant implants immediate in situations where you have huge buccal destruction, like here in the molar region. All the gaps are filled with PRF. We use a umbrella healing cap. This is an X-ray immediately after the implantation. The patient comes back 4 months later for the implant preparation and set the definitive crown. No complications. This is already 1 year follow-up. This is exactly what the new generation wants. No complications, no problems, everything light and shine. Also, during my analysis, I evaluate which area would be the most vulnerable area for fractures. And maybe you will also consider that this area is the premolar and molar regions of upper jaw. Since this analysis in 2021, we on Swiss Biohealth Clinic do not proceed any mediate implantation on these regions without doing the internal sinus lift. The internal sinus lift gives us the possibility of having 1 to 2 millimeters in between the implant and the cortex bone, an area where you can have your first stability or if you do not need the first stability, you still have this area to be filled with PRF. Let's take a look together. So after the preparation of the implant bed, using the protocol drills of SDS, you can see now the countersinker. You come with your instruments, proceed your internal sinus lift, gain your 1 to 2 millimeters, fill with PRF, and place your implant with no problems. That's it. Or in cases that if you do not proceed with the internal lift, you won't reach first stability. Like in this case, let's take a look together. So apicus cystus, a huge buccal destruction. You see the cortex after internal sinus lift, where the implant would be placed and reach the first stability. A completely destruction of the buccal wall. This defect is then filled with PRF, and that's it. This patient come back, and we have already 1 year follow-up. Of course, this is also very important where to place your implant. We usually place the implant as oral as possible to be able to have place between the implant and the buccal wall to be filled with augmentation or PRF. That doesn't mean if you do not place as oral as possible that you won't have osseointegration. Yes, you can have osseointegration, but as buccal your implant is, as greater the risk of tissue recession and compromising your aesthetic outcome. We can also proceed with the internal sinus lift on molar regions, as the example here. So after extraction, you come sometimes with no bed preparation because you actually don't need that. You just prepare with the countersink, proceed the internal sinus lift, gain your 1 or 2 millimeters, place your implant. In this case, we're placing the balcony implant, different shape of SDS implant that gave us the possibility of a physical barrier as well as maintaining the PRF inside the gaps and giving us also a better emergency profile for the future restoration. You can see exactly what you see in the schema here in this clinical case. Countersink, the drill is not necessary, we just proceed with your internal sinus lift. You can see the cortex right there, and safe place your implant, reach your first stability with 35 newtons per centimeter torque. This is also the balcony implant, and that's it. The patient then come back, and on the top you see the immediately X-ray after implantation and over a 4 years follow-up of this patient. Another point, and very important point, is which system do you choose? And we have two choices, the tissue level implants or the bone level implants. The tissue level implants are preferable because they are easier. You don't want to worry about how high your crestal bone or form of this crestal bone is to place your implant. Your implant is always placed supracrestally, avoiding problems of micrographs, micro movements, using abattements or screws that will further have problems on the subgingival area. As a tissue level implant, you can also proceed as a normal teeth, preparing this implant for the further restoration. The restoration is always placed supragingival, and you have enough area to control the cement, excess of cement if you have. Always supragingival, what doesn't happen with the bone level implants. Many studies have shown already proved the advantage of tissue level implants in comparison to bone level implants, and that is a lot with the bone level loss stability, as well as the plaque accumulation. That is much better for tissue level implants. And as we are talking about plaque formation, recent studies have compared the ceramic implants with natural teeth. And for teeth that are compromised, would be better to replace those teeth and have a better prognosis for the next 10 years. This is very often seen in our practice. This is one of our patients that come to us and have a complete treatment of her mouth. She has restoration and also place of ceramic implants, and that is immediately after the treatment, and this is after 4 years of drug abuse. You can see active caries, you can see a little bit of recession where the implants were placed, but you can see also that these implants are also integrated and very stable. How we did, we proceed with a new preparation of these implants and place of new crowns. And last but not less important is what the zirconia do with the epithelium tissue. This sealing is very well described since 1991, and I would agree with Professor Ganati when he says that whenever we implant zirconia, we implant a biomaterial. And with this closure, I hope to catch your attention to what is important for the future, the immediate implantation with ceramic implants at tissue level using blood concentrates and micronutrients. Thank you very much for your attention.